So this is going to be case-based. It's disease state, and I do love interaction. So show of hands. And we're going to talk about when to suspect a hereditary adenomatous polyposis and cancer syndrome. And I have a couple of cases that I think will illustrate important points to get across to you. Some of the disclosures, on the NCCN guideline committee for familial and genetics. So some of what I'm going to talk about comes out of that guideline. And I am the program director of a hereditary GI fellowship. So I'm going to target any of you to come to the Cleveland Clinic for a year to do this space. And then you can come back and join Dr. Kanth. The objectives today are to recognize the indications for individuals who should undergo germline genetic testing, how to interpret the results of genetic testing. Sometimes it feels like a big black box, and then help you design strategies to mitigate cancer risk in these patients and their families. So why are we even talking about this? 10% of cancers, including colorectal cancer, pancreatic cancer, and individuals with numerous cumulative lifetime adenomas will have a germline pathogenic variant that is causative of the syndrome. And once you identify that germline pathogenic variant, you take a different strategy to mitigate their risk, but also you can offer cascade testing to the at-risk relatives. So if you are affected with a germline pathogenic variant and your brother or sister or children, depending on the mode of inheritance, is tested and negative, they can go back to average risk testing. And if they're positive, then you know they need more early and more intensive surveillance. So a couple questions. Which of the following patients with the only cited risk factor should undergo germline genetic testing? A very young person with a 25 millimeter sessile serrated polyp, also known as sessile serrated adenoma. A young person, 58-year-old with a jejunal cancer, how rare are those? And a first degree with rectal cancer at the age of 77. Or an older person with a history of 20 adenomas, over 6 colonoscopies beginning 15 years ago. So who would say the very young person with this huge SSP? Show of hands. Okay, we have a few. What about these two cancers, one rare, relatively young age, and rectal cancer, older age? Who thinks that person meets qualifications? Okay. And then the older person that has numerous colonoscopies and you're finding 2 or 3 millimeter adenomas. Who thinks that person? Okay, so we had 3 hands for each of those. It is the last patient. So we'll talk a little bit about this. If you're studying for the boards or you're on GI Jeopardy team, this is probably a photograph that you want to take, and we're going to cover basically the 2 most common adenomatous polyposis syndromes that are hereditary: FAP and MAP. FAP is due to a pathogenic variant in the APC gene. And basically, it's colorectal cancer, duodenal cancer, thyroid cancer. They can have desmoids, and then they have the Gardner's phenomenon, and we'll review those kind of extra intestinal manifestations of the disease. And attenuated FAP is just a change in the APC gene, and it has lower numbers of colorectal adenomas and less frequent, sometimes upper GI syndromes. And MAP is kind of the cousin of the APC gene, adenomatous polyposis syndromes, but much less commonly will they get colon cancer, duodenal cancer, gastric cancer. The other very rare adenomatous polyposis syndromes, which are just discovered in Spain and other places in the last few years, include NTHL1 tumor syndrome, the polymerase proofreading associated polyposis, MSH3 and MLH3 associated polyposis, AXIN2, maybe on a board exam, it's oligodontia. So they have some unusual manifestations of their teeth and ectodermal neoplasia. And then MBD4 associated neoplasia, think about uveal melanomas and liquid cancers. And then the very rare syndromes compared to FAP and MAP are the hamartomatous polyposis features, but they're always fodder for board review. So in Peutz-Jeghers, they won't ask you about the pigment on the vermilion border in the buccal mucosa. They'll ask you about breast cancer or lung cancer, not the typical things that you would think would be on an SAT exam or board exam. Cowden syndrome. Macrocephaly is one of the tip-offs. Young children are being diagnosed with that because of autism. And then juvenile polyposis syndrome, due to two different genes, SMAD4 is associated with HHT manifestations. That might be a board exam. So this is kind of a good overview for a study guide for the GI boards. Okay, so this is our first case. I'm an open endoscopy, and it's a 48-year-old person that had a multi-target stool DNA test. And on the examination in a 30-minute slot, there were 13 polyps. You can see the size of them, and some of them are quite big. On pathology, 10 were tubular adenomas, 2 were tubulovillous adenomas with high-grade dysplasia, and 1 was a hyperplastic polyp. So not the typical thing you'd see in open access endoscopy necessarily. So let's explore some risk factors. I know we have people on Zoom, but I think anyone shout out, what are the risk factors for having adenomas? Anybody? One, give me one. Age, okay, give me another. Anything. What's that? Smoking, great, yep. What else? Family history. She has a personal history. What else? Yeah, diet. So you're talking about the lifestyle things. So just to get through it, we talked about smoking, alcohol. Alcohol is a class 1 carcinogen, by our Surgeon General in the United States and by the World Health Organization. No level of alcohol is safe. It's toxic. Body mass index, obesity predisposes, physical inactivity. No one mentioned race, so ethnicity has a big component to play. Gender, men are more likely to have adenomas than women, but the cumulative lifetime risk of cancer is about the same at the age of 80. We'll talk a little bit about diet, and we hit the colorectal neoplasia. So this particular patient, right, you're in a busy endoscopy, you remove all these polyps, some are quite big. You don't know really much about the patient. Maybe you said, do you have a family history of colon cancer? Non-smoker, no drinking, BMI is less than 20, regular physical activity, white, female. I said, what do you eat? Well, an average American diet. I have to admit that I do eat chips occasionally, so I'm not really worried about the diet. And she, other than this, has no personal history of cancer or neoplasia. So we don't know much about her family history, but in terms of the lifestyle factors that you should counsel your patients on in general, not just for neoplasia, but for all lifestyle related diseases. This is 2 different studies, and this includes from NHANES study. You can see the percent attributable fraction risk to colorectal cancer by smoking, alcohol, obesity, in terms of diet, red meat, processed meat, low fiber, and low dietary calcium. So don't underestimate hypovitaminosis D, and I oftentimes check it in my patients. And then another study looked at vitamin D, and you can see that even in rates that we think are 30 to 50, that's kind of a normal range. It is associated with substantially increased risk of colorectal cancer. So vitamin D is also important. So for this patient, we saw her, we did her procedures, we got her pathology. What's the next step for her? Anybody? What do you want to do next? Send her to Dr. Camp. Take a history. That's very important. And the components of a family history are 3 generations, right? So you want to know about parents, grandparents, siblings, of course, children, aunts and uncles, the presence of an age of cancer, if it occurred in the family, and the age of cause of death. So I've had patients that are adopted. They don't have a family history, or their parents died in a car accident at the age of 48. So it's a non-informative family history. And then with that table of things that I showed you, there are extraintestinal manifestations that you want to query. How old were you or the relatives when they had an adrenal adenoma or an adrenal cancer? What are not only the intestinal, but the extraintestinal manifestations? And then for people that are in the space, how many polyps, what type of polyps, and, size, things like that. So here's this person's family history. I can't hide something in there that wasn't on my slide when I looked, but what I've highlighted is the proband is indicated with an arrow that says polyposis at the age of 49. She had a brother that had nothing on his colonoscopy, but her father died early of a glioblastoma, and his parent had a thyroid cancer in an older age. There was a half cousin that had a rhabdomyosarcoma at a young age. And then there was colon cancers in the maternal side of the family, maternal uncles that you can see there. So something smells pretty sniffy about this pedigree. And so if you're a gastroenterologist and you see this patient, you do the colonoscopy, you're going to look at the US Multi-Society Task Force guidelines and say, oh, what am I supposed to do? So what you can see here after high quality colonoscopy is on the far left of the slide that individual should come back for a 1-year colonoscopy if they have 10 or more adenomas on a single exam. And if you look in the small print, it said patients with more than 10 cumulative lifetime adenomas should be considered for genetic testing. So what are the indications? Most of this talk is about adenomatous polyposis syndromes, but we'll talk a little bit about when a patient presents with colon cancer. So what does the NCCN say about patients with colorectal cancer? All patients who have the diagnosis under the age of 50 and should be considered in individuals that are 50 years or older. In terms of tumor characteristics, and you have an NCI designated cancer center here, so on your colon cancer specimens, you're probably getting these types of results. So you're looking for evidence of mismatch repair deficiency, either on immunohistochemistry, where they're staining for the genes, or actually the proteins produced by the genes that are in the Lynch syndrome pathway. And what you can see on the tubulovillous adenoma on the bottom left is brown nuclei staining in the tubulovillous adenoma, and there's brown nuclei staining in the base of the cancer. So that is normal or intact expression of the protein, as opposed to on the right side of that figure where it's lacking expression of MSH2 protein, which indicates that this person likely has Lynch syndrome. Or your lab might do microsatellite instability testing where they compare the electropherogram in certain di and mononucleotide repeats. And if there's disparate profiles in the tumor and the normal tissue, that is also a tip-off and is important because you treat patients with microsatellite unstable cancers in a different fashion than if they were microsatellite stable. And then lastly, there are online models that can help you predict the likelihood of getting a Lynch mutation on a genetic test. So there's PREM5, there's PREM6. And basically what the NCCN says is genetic testing is recommended if the risk estimate to detect a gene is 5% or greater, and that consider it when it's 2% or greater. For the polyposis syndromes, it's slightly different. So recommendations are things that are kind of strongly advocated for, more evidence to support them. Greater than 20 cumulative lifetime adenomas, a known germline pathogenic variant in the family. If people have these odd extraintestinal manifestations of FAP, the freckles in the back of the eye that are multiple and bilateral, a specific type of thyroid cancer, the cribriform morular papillary thyroid cancer, and family history of polyposis, and maybe the family is not available to test or the family member is unwilling to test. And then you consider it when someone has 10 to 20 cumulative lifetime adenomas, desmoid tumors, hepatoblastoma, unilateral TRPE, and individuals with serrated polyposis syndrome. It is the most common non-hereditary polyposis syndrome that you'll see in about 1 in 242 patients. It doesn't hit you in the face. It's oftentimes you have to track over multiple exams, but if they have at least some adenomas, they should be tested as well, considered. So the causes, if we're thinking about, this is a hereditary lecture, what's going to be board fodder? The germline polyposis syndromes, by far and away, 99% of people with these genetic syndromes, it's going to be FAP or the MUT-YH associated polyposis. And then those other unusual ones I talked about are much less than 1 to 2%. We're rarely seeing them. Less evidence is available to guide us. But if we're thinking about the person with cumulative lifetime adenomas, they're going to be non-hereditary. We'll talk a little bit about colonic polyposis of unknown etiology. But again, serrated polyposis is another disorder that you need to think about when people have serrated polyps that meet the WHO criteria and numerous adenomas. Okay, when it comes to genetic testing, if you worked with Dr. Kent, you can do single site testing. Like, oh, my mom has Lynch syndrome. She has an MSH2 mutation. And so I only have that test. Well, that works great if the family germline pathogenic variant accounts for all the cancers that you see in the family and all the manifestations. But if it doesn't, then you want to do something called multi-gene panel testing because it might give an explanation for the prostate cancer or for the sarcoma or for other breast cancer, things you weren't anticipating if that one single gene didn't account for it. And of course, if you don't know the familial pathogenic variant, multi-gene panel testing is the way to go. What's the advantage of doing multi-gene panel testing? It's best if 2 or more genes could explain the syndrome that you're looking at. It's customizable. You can limit it to a pan-cancer panel, a pan-syndrome panel, or just cast a broad net. It's really cheap and generally covered by insurance. And if not, it's probably $150 out of pocket, depending on your insurance. So you basically get faster results that might impact surgical decision-making. And then you have the higher chance to provide your patient with an explanation. So many patients feel guilty. What did I do wrong that I have so many polyps or I got cancer? So, being able to explain this is very helpful. But you have a greater chance of detecting variants of uncertain significance. We don't know what they mean, so it doesn't impact our management. And then you could have unanticipated things. I've had so many patients that went to have a panel test because their father had prostate cancer, there was a pancreatic cancer, and they get diagnosed with CDH1, the hereditary diffuse gastric cancer, lobular breast, completely unanticipated. And now this person, who's 60 years old is dealing with something they never anticipated. And it doesn't inform medications for, the type of tumor that you've detected. There are guidelines that say there's a proposed minimum number of adenomatous polyposis genes that should be in a panel. So I've listed them there. And we'll talk a little bit about, in this patient, there was a thyroid cancer, there was a brain tumor, there's all these polyps at a relatively young age. So in my mind, I'm thinking this could be hereditary. It could be FAP. Medulloblastomas are part of it. Thyroid cancer is part of it. So the prevalence of an APC pathogenic variant has traditionally been reported as 1 in 10,000. But there was an interesting study at Hershey where they offered my genome to patients walking in off the street, and they found that 1 in 2,800 individuals actually harbored an APC pathogenic variant, probably very low penetrance, maybe never would have been picked up clinically. As I said, the cause is due to an APC mutation. 30% are de novo. So even though it's autosomal dominant, 30% of cases don't have a preceding family history. And there's some genotype-phenotype correlations, which can explain the number of colonic polyps and the lifetime risk of cancer. Here's the typical cancers that you will see in FAP, of course, colon, there's duodenal, ampullary, gastric, the thyroid cancer, and then very rare hepatoblastoma in young individuals between the ages of 2 to 5, and then brain tumors. Here are some features of those extracolonic manifestations. So on the upper left, you can see freckles in the back of a retina. That is called chirpy. You can see the osteomas and subcutaneous cysts on a patient's forehead on the top right. You can see the gastric polyposis below the chirpy, the duodenal polyposis below the gastric polyposis, and then you can see the colon that's just loaded with polyps and ability to survey. So they have even ectodermal things, extra teeth that didn't erupt, osteomas. They have a variety of different manifestations of the disease, and we'll talk a little bit more about the intestinal manifestations. As I said, MAP is thought to be the cousin of FAP, but it's autosomal recessive. And the carrier frequency of one MYH pathogenic variant is 2% in the Northern European population, so not so uncommon. And these tumors can be microsatellite stable or microsatellite unstable, which impacts some of the manifestations of disease, but potential treatment if there's a cancer. And generally, throughout the GI tract, the disease is more attenuated than compared to FAP. Importantly, patients with MAP can develop colon cancer or duodenal cancer without having any preceding adenomas. So it's really a sneaky disease. So I've listed there, some of the frequencies of the other diseases associated with it. Bladder, ovarian, and skin are also reported. So the patients in front of you said, hey, I think you need to have genetic testing. What's this about, doc? What are they going to tell me? Why is this important? So she wonders, how likely is it that the gene will explain her polyps and the family history of cancer? So who would say 80% likelihood we're going to find something in this affected family? 50%, 10%, 0%. Okay, we have a smattering throughout. So this is an old study from test requisition forms that looked at the frequency of detecting a germline pathogenic variant in only MUT-YH or APC. And if you look at our particular case, you could see that both of those genes were detected in individuals with 10 to 19 cumulative adenomas. So that's about a 9% hit rate. So you could say, hey, listen, this really old study that only tested for these two most common things, it's about 10%. we would manage you differently. And then more recently at Ohio State, Pete Stanich did a cross-sectional study of, again, test requisition forms, and patients needed to have 10 or more polyps with at least one adenoma. And when you take a look at this particular patient, you could see that polyposis gene is picked up 2.3% of the time. And a Lynch gene, 3.1% of the time. And then the Hereditary genes much less commonly, but about 5.5%. And this is using kind of a more contemporary panel. So you could say, hey, somewhere between 5 to 10% of the time. And so when you get these results back, you need to know what to tell the patient. So if it's pathogenic, also known as likely pathogenic, that's actionable. You basically treat the patient based on the guidelines that are available for management. And then you can offer the patient's family at-risk relatives cascade testing. The VUSs, as I said before, they don't help. So even if I had an MSH2 germline pathogenic of an MSH2 loss of expression in my tumor, but my germline was negative or had a VUS, there's more genetic testing and assessment that needs to be done, but you really can't treat someone based on a VUS, even though it seems like it would go with the disease. And the one that's negative, people go to average risk surveillance. So here's the panel that was done on my patient. You can see a ton of genes, well beyond adenomatous polyposis genes, were tested. Who thinks it's going to be positive? Show of hands. 2 people. Who thinks it's going to be negative? Okay, it was negative. So then the patient says, what's my diagnosis? What do I tell my son? Her other son died at the age of 16 of sudden cardiac death. So she's worried about her family members. And then she wants to know, what do I need to do to follow up? So what she has is defined as colonic polyposis of unknown etiology. So it's a patient that has 10 to 20 cumulative lifetime adenomas, and they don't have a germline pathogenic variant on testing. So in this particular case, the NCCN on the far left says, hey, a colonoscopy and the interval should be based on the clinical findings and factors, and consider an EGD by the age of 20 to 25 years. The individuals that has 20 to 100 cumulative adenomas, you manage, I call it FAP light. So colonoscopy every 1 to 2 years, an EGD at the starting age, which we do for FAP, and then you follow the duodenal polyposis surveillance guidelines, and a colectomy when needed. And then when people really look like they're FAP, more than 100 adenomas, then it's the typical FAP-related surveillance for the patient. Okay, so what is the data? If they say consider an EGD and 10 to 19 adenomas, really, what's the cost effectiveness? What are we finding? So this was another study by the Stanich group at Ohio State in 128 patients, 5 different centers. And you can see on the right side of the slide that many of these individuals had a full panel. So 100% had APC and MUT-YH testing, but they did really test lots of other things, including the Hereditary polyposis. And if we're talking about our case, and she said, well, why do I need an EGD? They found duodenal adenomas about 5% of the time. So not a big yield, but a yield enough. And then we also did a study, and ours is limited. It's single center, 126 patients, and 100% had APC and MUT-YH testing, and much fewer had the other unusual polyposis genes tested. But in our particular case, you can see gastric adenomas were detected in 8% and duodenal adenomas in 33%. So there's some data that you could share with your patient about, hey, there is a yield, let's do it. So she underwent an EGD, including biopsy of the papilla. That was normal. And I said, come back in 5 years because there's something sneaky about your family. And because she had numerous and large colon polyps, I said, come back in 1 year and then we'll lengthen the surveillance. And then for first degree relatives for 10 to 19 adenomas, I'm basing it on the clinical judgment. Okay, so let's talk about another case. This is a person that was seen outside the Cleveland Clinic and referred in, a 45-year-old guy who had rectal bleeding. And when they did the colonoscopy, he had 45 less than 10 millimeter tubular and tubulovillous adenomas and a rectal cancer. The rectal cancer was about mid-rectum, about 8 millimeters in size, and it was microsatellite stable, so that he was sent to the Cleveland Clinic for follow-up. Prior to coming to the Cleveland Clinic, he did have genetic testing. So he had a commercial panel that includes all of those different things that you see there. And it was negative. Here's a pedigree, which is a very helpful thing. The proband, again, is indicated by the arrow, age 45. He has a sister who's 43 that's had no polyps. He has 2 children, ages 12 and 13, and there's nothing compelling in his family history, right? Parents 69 years old, his dad had a couple polyps, his mom hadn't had a colonoscopy, but you can see not quite a big family as the other case, but nothing is there that's really compelling. So what I want to talk to you about is APC mosaicism testing, right? So mosaics can span the spectrum of many diseases, but can be in Lynch syndrome, it can be in the Hereditary Polyposis syndromes, and can be seen in FAP. And basically, this is a post-zygotic phenomenon. So when the embryo is at the 16 cell, it's a blastocyst, you can have changes in different cell populations. And so if those cells have an APC pathogenic variant in them, it can go to the colon, or it could go to the duodenum, or it could go into the sex cells. You don't really know where it is. And 20% of these 30% of de novo cases where they don't have a family history, they show up with rectal cancer and lots of polyps, are due to this condition. So basically, when you're faced with this, and I don't know, Dr. Kanth, are you guys doing frequent mosaicism testing? Yeah, rarely. You have to test 2 different tissues, and you're going to say, well, why are we doing this anyway? But you test 2 different tissues for an APC pathogenic variant, and basically you send off, 2 adenomas, or you can send off a cancer and an adenoma, and then another tissue, because there's 3 different embryonal, germ layers that can be affected, and then you send it to a specialized lab. Not many labs do this. And if it's positive, which means when they looked at these 2 different polyps in the colon and found the exact same APC pathogenic variant in it, then they also test the blood. And if they find that in the blood as well, you can offer testing to the at-risk relatives. So it's very helpful for the patient to explain what's going on with them, but to also know, rather than just saying, oh, you don't have anything in the germline, we can't test your kids, they just need to be surveyed as if they have FAP for, until they're older. So it's very helpful, but negatively, if you don't find anything, you can't offer cascade testing to the family members, and then you basically follow CPU recommendations. So I just want to show you an interesting report. So the top line is the same APC pathogenic variant was found in both tested neoplastic tissues, the 2 adenomas, and present in the tested germline sample at low levels consistent with constitutional mosaicism. So when you send genetic testing off for these germline pathogenic variants, they'll call these autosomal dominant or recessive syndromes if about 50%, if the variant allele frequency is 50%, right? These labs aren't looking down to find a variant allele frequency, a VAF of 3% or 15%. So if you take a look at what I highlighted in yellow, 1 adenoma, they found the APC mutation, 23% VAF, 29% in the other polyp. Doesn't matter what the VAF is, it's just that the presence of 2 distinct APC pathogenic variants in them. And then it was found 3% in the blood, which the lab wouldn't have picked up. So this person wouldn't be called FAP. But now we could give it the name, you have FAP. And now, since we know the APC pathogenic variant, you can test the kids, you can test the sibling. So this is kind of a nuance in genetics and is really helpful. So in this case, it's FAP. What do we do for his children if they have it, or basically anyone with FAP? Annual colonoscopy beginning at the ages of 10 to 15. In attenuated FAP, every 1 to 2 year colonoscopy starting a little bit later. And then an MAP, again, 1 to 2 years beginning no later than 25 to 30. And if you're faced with scoping these patients with Dr. Kanth, you should resect all polyps that are greater than 10 millimeters in size. And if they have few, basically, anything 4 millimeters or greater, or all if it's feasible. And then you want to refer to a colorectal surgeon just to have them as part of your care team. And when do surgeons need to operate? If you're at St. Mark's in London and you have 1 adenoma and you're 16 years old, they're doing a total proctocolectomy and iliopouchianal anastomosis. At my institution, we weigh many things before making a surgical decision. But of course, if someone has cancer, you need to have surgery. If they have unremitting symptoms because of the polyp burden, surgery. Endoscopically unresectable big things or things with high-grade dysplasia. Or if you have someone that has so many polyps, you can't confidently say, I'm worried there isn't a cancer there, Or I would say a strong relative indication would be the patient that says, hey, listen, one crack to me and I'm never coming back again. That's a person you want to offer surgery. And then relative indications. I see people, I'm taking care of them. They have 500 small adenomas, but more than 1,000 adenomas, most surgeons would operate. If you have lots and multiple with high-grade dysplasia or big, a clinically significant increase in polyp burden between two examinations, right? If someone's taking off from 200 to 400 and has some big or advanced. And then patient preference. Hey, listen, doc, I know I need surgery, but I'm starting school at Georgetown. Could you just scope me every year until I get through, and then I'll have my surgery. And once you do surgery, then don't forget what else needs to be looked at. So sigmoidoscopy for patients that have had an IRA or a pouch every 6 to 12 months, depending on polyp burden. Most of our patients are on a yearly interval. And then the data to support end ileoscopy for end ileostomy. Basically, there's cancers reported on the stoma. There's rare cancers reported in the ileum. So at least every year when the patient comes in for a check, look at the stoma, take the bag off because polyps can form there. And then doing the ileoscopy itself every 1 to 3 years. But that's limited evidence. So if you guys want a research project, that would be a great one to do. And then we use a GIF scope and 2 enemas on site for our, I get reports of from outside saying, we did a colonoscopy to the IRA at 20 centimeters. Well, that's not really a colonoscopy, but you can use an upper scope. You don't need a colonoscope. And enemas on site generally work. The duodenum is an organ that you can't forget. And as gastroenterologists, you're part of that care team. So adenomas can be seen in up to 90% of individuals. And duodenal cancer is about 13%, and usually at an older age. And the highest risk of people getting that is the Spiegelman stage of duodenal polyposis. It goes from 0 to 4. But we did some study and showed that 50% of our patients that developed duodenal cancer never got to stage 4 duodenal polyposis. And then there was a recent meta-analysis and systematic review that showed that the sensitivity of stage 4 for predicting duodenal cancer was only 50%. And the most informative features of the Spiegelman stage are high-grade dysplasia or large polyps. So more than 20, or you have 50 that are 1 millimeter in size. Those people are not at the highest risk. It's basically size and pathology. So the EGD and FAP, an attenuated FAP begins at 20 to 25 and 10 years older in MAP. Visualize the papilla. If you can see it well with a forward viewing scope, you're good. If you need a cap, put a cap on and a side viewer if needed. But there are studies that showed that up to 80 to 90% of individuals, you can see the papilla well with a cap. Biopsy if it appears abnormal. And then please, in your endoscopic reports, utilize the Spiegelman characteristics. So the Spiegelman staging includes a variety of features, some that you'll have during the time when you're done with the endoscopy, others require pathology. The number of polyps, the size of the polyp, the histology, and the degree of dysplasia. And basically, as you increase the size, you increase the number, you increase the pathology, and the degree of dysplasia increases, you add up those points, and then that gives you a score. And the score is important because it not only gives you the stage, but it also gives you an appropriate interval to follow someone on and the ensuing cancer risk. So you can see for people that don't have any duodenal polyps, basically their 10-year likelihood of getting a duodenal cancer is less than 1%. And so they can be rescoped in 3 to 5 years. If you have stage 2 or 3, you increase the interval. Their ensuing 10-year risk of duodenal cancer is 2 to 3%, so still very low. And then you can see when you're stage 4, those individuals should be having their EGDs every 3 to 6 months. You want to maybe consider sending them to an expert center, which you probably have here. And their ensuing cancer risk is about 16%. And those the individuals, if they can't be endoscopically managed, really need to be seen by a multidisciplinary team because surgery probably is the best option for them. We've written a lot of papers in GIE and other journals. Endoscopy always want us to take out biopsy of a normal papilla, and they're worried about biopsy of an abnormal papilla. But one of my early studies is that when I was a fellow in the early 90s was looking at the ampulla in patients with FAP. Adenomas are common. 60 to 90% of patients with FAP will have an ampullary adenoma. Do all of them need their a papillectomy? No way. because it's morbid and they recur. So the study that I did said, I'm looking at it. Let me take a biopsy if it looks abnormal. And basically 90% of the time it had adenoma on it. And when they looked normal and I took a biopsy, 54% had microadenoma. And the Europeans have also published this work, the Italians have as well. Ampullary cancer is associated with the Spiegelman stage of duodenal polyposis, Spiegelman stage 4. So you can see that I've listed that, 1 to 2% if you don't have duodenal polyps, 4% if you have stage 2 or 3, and up to 12% in an individual that has Spiegelman stage 4 duodenal polyposis. The papilla is not included in that staging system, but maybe needs to be reconsidered. And again, in the 5th and 6th decade of life. So I just want to talk a little bit about biopsy of the papilla. We have some advanced endoscopists here. Who is worried about biopsying a papilla because of the risk of pancreatitis?
Well, luckily it's very small.
Look, how do you know it's small?
Over the year.
Oh, okay. Data should back that up, right? So so we did a study of 273 consecutive patients who had 1 or more biopsies of the papilla over 792 EGDs, 1 to 8 independent exams with biopsies per patient. Pancreatitis developed in 2 of these individuals, so less than 1%. 1 after biopsy of a normal papilla, the patient actually had P. divisum, and 1 after a biopsy of an abnormal papilla. But importantly, in our study, the pathology increased the Spiegelman stage in 13% of these individuals, and a small number of these individuals went on to a prophylactic duodenectomy. So I just want to say, don't worry about biopsying the papilla. Editors say, well, where do you biopsy and how many? I mean, I sometimes biopsy right on the papilla. It doesn't have to be on the side. And sometimes I take 2, but the risk of pancreatitis, I think, has been overestimated in people's minds. And as Dr. Haddad said, it's quite uncommon. And so talking about ampulectomy, we published this other study looking at the natural history of ampullary adenomas. And what we looked at is clinically significant progression, which is defined as an increase in size or an increase in histology. And these individuals had about 8 years of follow-up. And you can see that nearly 3/4 of individuals that had an ampullary adenoma didn't progress over that period of time. 2 patients, or 5%, went on to an ampullary cancer, and a small number of people had clinically significant progression. So 143 consecutive patients, 2 or more EGDs, 1.4% developed ampullary cancer. And the factors that were associated with this was an abnormal appearance at baseline, men more likely than women, someone that had a prior cholecystectomy, and I don't know if it's related to maybe bile stimulation of something going bad, or it could have been that maybe their ampullary adenoma was causing biliary symptoms and they had a cholecystectomy, and then personal history of extracolonic cancer. But there are risks associated with ampullary adenomas, and the majority of individuals that have them will have a recurrence, even though it's endoscopically manageable. We submitted to the ACG the guidelines for management of adenomatous polyposis syndrome. So this is one of our PICO questions. So individuals with ampullary adenoma without an indication for duodenectomy, we suggest endoscopic ampulectomy over surgical ampulectomy for an ampullary adenoma 10 millimeters or greater in size, or with high-grade dysplasia, or any size associated with pancreaticobiliary symptoms that have no other reason to have them, and that you don't have intraductal extension of the adenoma 10 millimeters or greater in size. So conditional recommendation, low quality of evidence. So we really need more data in this space also. Gastric polyposis, the Utah Registry published this. We've published this, even though fundic gland polyps are prevalent in the proximal stomach. And we used to think, and Randy Burt said, gastric cancer is really not a phenomenon in FAP. We know that is one of the leading causes of death in patients under surveillance in FAP, and it occurs up to 5% of the time. And we know endoscopic features. So we'll talk a little bit about those features. The endoscopic features, carpeting of proximal polyposis, solitary large polyps, polypoid mounds, and proximal white mucosal patches. So those are the features that you can see with endoscopy. But then the pathology would be the adenomas, whether they're foveolar or intestinal or pyloric gland adenomas, because we think those are the precursors for cancer in FAP. Hyperplastic polyps, of course, when they're big, they can be associated with high-grade dysplasia or cancer. And then another high-risk polyp is, anything smaller than that, even a fundic gland polyp with high-grade dysplasia. So we've published this in JNCCN. It will also be in the ACG guidelines when those are published. But if you take a look at the far left of the slide, you can see what carpeting means. But it's like pornography, where it's in the eye of the beholder, what you think is, pornographic. But I had a young woman that came from Chicago with gaps, and they reported a carpeting of polyposis. But the definition is polyposis encompassing continuous areas of the proximal stomach with no or limited intervening normal mucosa. So on the images of this kid, you could well see normal mucosa. So yeah, there was a lot of polyps. There's probably 1,000 polyps, but carpeting really means you can't really see any normal mucosa. The white mucosal patch. The European group had a small case, 2 cases said, oh, if we use NBI, we can see that better, but you can see that well-defined, circumscribed white patch, usually in the fundus or proximal body that overlies polyposis. Usually it's greater than 2 to 3 centimeters in size. And then these polypoid mounds, when you have a stomach that's full of carpeting and these mounds, can you tell that patient they don't have cancer? And so, now we're debulking all these polypoid mounds and we're actually decreasing the risk of cancer, but it's still occurring. And so the NCCN provides some guidance on, what should be resected, when the follow-up should be, and then when surgery should be considered. So I've listed here a variety of, that for you, so you don't have to go to the ACCN. But antral polyps are usually adenomas. They should all be resected. They could look very subtle. And then adenomas can be a little bit tricky to find. So we published in GIE something called the SPACE criteria that has some NBI related criteria and some white light criteria for you to help to identify the high risk polyps. And then in general, if you have fundicland polyps that are less than 10 millimeters in size, low-grade dysplasia is seen in 50 to 60%. That person doesn't need a Swiss cheese approach to remove all these fundicland polyps. Those are not high-risk polyps. So when it comes to upper tract surveillance, right, you say, oh, I'm looking at the Spiegelman stage, and the Spiegelman stage is 1, so you can come back in 3 years. But you need to marry that with the organ with the most severe phenotype. So if you have the stomach on the upper right and you have the duodenum on the bottom left, you're not going to tell that person, oh, come back in 3 years when you have a stomach that looks like that. So keep in mind that these are 2 different organs, both at risk. And so you want to strategize and do what frequency that's the soonest between the organ that's most at risk. And then sometimes we've forgotten about it for years. Once you take someone's stomach out, you still need to look at the duodenum. So don't forget that. Or if patients have a Whipple or a pylorus preserving pancreas sparing duodenectomy, there is still the jejunum at risk where you have your hepatojejunostomy and the pancreaticojejunostomy because it's bile that fuels duodenal adenoma. So, get your partners who do balloon enteroscopy if needed, or using a pediatric colonoscope to get to see where the orifices are reimplanted. So yeah, got to keep your eye on the excluded organs. And then here is some guidance, the evidence to support what to do for all these really rare syndromes, POLD1, NTHL1, MBD4, AXIN2. No one really knows, but the NCCN is basically has some things, and this is what we're putting in the ACG guidelines, looking at the age of cancer risk. Mostly these are colon cancer syndromes with other cancers. So colonoscopy, 25 to 30, intervals every 1 to 3 years. EGD only in POLE and POLD1, because those are the only 2 syndromes that really had duodenal adenomas or duodenal cancer. And then, of course, if people need surgery, then you follow them like you would do for FAP. Don't forget thyroid surveillance. It occurs both in attenuated FAP, and we have some data on MAP as well. You can't feel the thyroid cancers, so you have to do a thyroid ultrasound. We have our endocrine surgeons that have clinic slots. So when our patients come in for their procedures, then they walk over to endocrine surgery and then they get their ultrasound. And repeat every 2 to 5 years if normal. We've had cancers at the age of 15 or 20. It's usually females at a young age. And, send them to a thyroid specialist if there's nodules that need to be followed. And also FAP patients are at increased risk of Hashimoto's. There's been some pushback to say, hey, it's just lead time bias, right? They never would have died from that cancer. You're just finding things early. But we have had patients who've had metastatic papillary cancer and needed lymph node dissections, and no one really dies from it, but it can be a morbid disease. So in conclusion, having a suspicion of hereditary colorectal cancer and adenomatous polyposis syndromes requires some thought and genetic assessment. And germline testing is not a black box. You can learn how to do it. Our oncologists do it. Our breast surgeons do it. Our GYN oncologists are doing it. And it's indicated in many scenarios. With the 2 cases, I hope that you don't forget about mosaicism when you're shaking your head and like, oh, this really scratching your head. What else could be going on? Mosaicism testing can be very helpful, although not paid for by insurance. Although one lab is offering it currently for $900. And there's going to be something else for $1,200. And then the management of your patient, of course, is guided not only on their phenotype and the family phenotype, but on their genetic testing results. And I said some of my disclosures, but this is my shameless plug for a great opportunity for a 1-year hereditary training. We have a colorectal fellowship. So a fully trained colorectal surgeon or a fully trained gastroenterologist. You could be out in practice for 3 years or 5 years, or you could want to do an advanced year. But basically it's advanced in intraluminal resection and hereditary GI neoplasia. So all you'll see for the 1,000 procedures you do over that year is basically hereditary patients working with our surgeons, going to the operating room, our subspecialists, pathology, and we have an animal lab where you could work on high-risk resections, ESD, so you have some experience with that too. So that was Lady Catherine, our first Burke Sheetz fellow. And she is going to come back to join us when she gets her visa arranged, but it's a great opportunity if you guys, happy to talk to you offline, or if you want to take the QR code, we'd love to have you.